I want to welcome Dr. Dressner to talk about breast cancer, the biology and the discrepancies in the management. Lisa, please welcome aboard.
Can everybody hear me? I usually talk loud enough for everything. I'm talking about breast cancer, and we're going to find out that there are disparities of care and also the differences in biology. And I'm going to explore that a little bit, and then we'll come up with a hypothesis on how we can address the issues. So breast cancer is an important issue, but it's an exciting issue for surgeons because we have a direct impact on the outcome of care. And it's one of the cancers that we have a lot of definitive treatments for, and that there's good survival. And on average, in the United States, there's 280,000 cases per year. It's a very common cancer, but 90% 5-year survival rate. So not only are patients getting breast cancer, but they're surviving it and living with it. So treatment and screening has improved outcome over time. And as you can see, it's because the number of cases had a small blip with hormone replacement therapy, but then it went back to and screening, and then it went back to the steady state. But the death rate from breast cancer has declined slightly over time, and the overall survival has increased. The relative overall survival is impacted, though, by screening, picks up ductal carcinoma in situ. So while it's a big impact, looks like a big change, it's a moderate change over time and decrease in improving survival. Sorry. I pressed the wrong button. Here we go. Okay. But we're going to break it down by ethnicity, and there seems to be some interesting information here. There's two issues. One is there's difference in incidence of breast cancer divided by ethnicity, and by race and ethnicity, and the deaths and the death rate are different. So as you can see, the incidence of breast cancer in white women versus black women, actually it's slightly more common in this study in white women, but the death rate is substantially higher in black women. In contrast, the incidence in American Indian and Alaskan Natives is lower, and the death rate is similar to white women. Leaving us with perplexed how much of this is biology, what is this about, these groups of people that give them more breast cancer, and what causes them to have different outcomes. And this is the data splayed out in a different way by year. So as you can see, the incidence, this is dividing African American, black women, and white women, and you could see that the incidence has risen over time but flattened out, with white women having a greater incidence of breast cancer than black women. But the death rate and the mortality over time has decreased much more substantially in white women than in black women. And this is perplexing, but we have some clues as to why. And this is another interesting graph I found out there, and it sort of gave us an impact of the treatment and modalities and why this may happen. Why would the death rate in white women be going down? And we know that over time, screening has had a big impact. Screening has become widespread. You'll see data later that about 70% of women have had a mammogram in 2 years, and this is across actually all ethnic groups. The addition of chemotherapy, adjuvant chemotherapy, to decrease recurrence and improve overall survival, and the addition of other targeted therapies like tamoxifen, Herceptin, have had a significant impact on the outcome, but it seems like this outcome has mostly benefited white women. Okay, so what is going on? Well, is there a different biology? Is there a different natural history? Are people getting different breast cancers? Is there different genomics? The patients have higher risk or different risk? Are there different patterns of care that are contributing to this? And what do we need to adjust to when we're treating breast cancer based on patients' ethnicity? Are we studying white women more and treating all patients like we should be treating one group of women? Are we grouping everybody together and looking at that data and then applying it incorrectly on subsets of patients with what is a different disease, could be a different disease? And then, do we need to identify more targeted treatments? And the answer of that is, of course. So one of the first clues that we have some differences in at Black versus white women is age diagnosis. And remember, I talked about that the incidence of breast cancer is slightly lower in African American women, Black women, but that's not true in young women. That ratio between white and Black incidence is a little bit higher in Black women and young patients. And remember, you're more likely to die of any cancer if you get it younger, and that is also true in breast cancer. And so age-specific incidence is different between, and this is specifically invasive breast cancer between white and Black women. So the consensus is more cancer in young women, less in older women. The stage of diagnosis. The stage of diagnosis is different, and people can ascribe the stage of diagnosis because of delays in care, or it could be different disease. So as you can see that white women are more likely to present with localized disease than Black women, and Black women are more likely to present with regional and metastatic disease. So this was an interesting study that helped sort this out. And they looked at differences in breast cancer stage diagnosis and cancer-specific survival by race and ethnicity. And they looked at, you should know there's a big database called the SEER database. Almost all of the outcome data is people looking at this database, asking questions, and then coming up with answers. And this one, he looked at 200,000 women in this database with cancer size less than 2 centimeters in size. And the first thing they found is that specifically, who presented at stage 4? These are small cancers. They're supposed to have good outcomes, right? Early stage breast cancer. So you can see, and you could see stage 4, Black women had a higher rate of presenting at stage 4, even though they presented at less than 2 centimeter tumors. And they had higher node positive rate, again, more likely to be node positive. And in fact, they were less likely to, Black women were less likely to be ER positive. And with Black women with small tumors had a higher percent that were triple negative. So you could see there were significant differences even in women who presented with small tumors. So differences in screening and differences in access to health care doesn't seem to likely to impact this because these are small early cancers. They looked in the same study, he also looked at deaths at 7 years in patients with T1 and 0 breast cancer, stage 1 breast cancer, all less than 2 centimeters, clinically with negative axilla. These are early stage breast cancer, and these should have very low death rates. And there were low death rates. But as you can see, Black women were more likely to die, significantly more likely to die. And in fact, different Asian women were less likely to die. Suggesting that there's some biology of disease happening here that's different. And then we're going to talk about what that difference is that way. And it came out to 9% more likely to die. And this difference was also seen in inflammatory breast cancer, the worst, most aggressive breast cancer. These patients all present as T4 disease. About 40% have metastatic disease at presentation. And in this group, the outcome was significantly better in white women than African women, with Hispanic women doing poorly. You could argue that this is a marker for differences in care, as you would expect these both very virulent, high-grade, terrible tumors to all have terrible outcome. And perhaps this is evidence that there is different care being delivered. Looking at the next thing is, well, what are different about the tumors? And one way we look at breast cancer tumors is at tumor markers. We look at estrogen receptor, hormone receptors, and Herceptin receptors. And you can see that Black women had a lower rate of being ER positive, HER2 negative tumors, which are the easiest to treat. They're treated with tamoxifen or aromatase inhibitors. And the higher rate of triple negative breast cancers, that's breast cancers without tumor markers. They had similar rates of ER-positive, HER2-positive tumors and HER2 alone positive. And I put that slide, that little graph about the change in therapy. Those specific markers, tamoxifen, aromatase inhibitors, Herceptin blockers, all of those are relatively modern additions to targeted therapies to the treatment of breast cancer that are quite effective. And triple-negative breast cancer can only be treated with conventional chemotherapy, usually Adriamycin-based chemotherapy. So in these patients, if you have a bad breast cancer that's ER-positive, you first can get your chemotherapy, and then you get your hormone therapy and have long-term good results. While patients with triple-negative breast cancer really don't have specifically targeted agents, and may not be benefiting from modern care. This is to show you how we can type breast cancers in big groups, so that if you haven't heard before, we talk about those nice ER-positive tumors that have low recurrence scores as luminal A's. And as you can see, the red is where they have increased uptake. So that's all the immunohistochemistry typing across. And luminal A's are the typical postmenopausal breast cancers that are the most common. Luminal B's are ER-positive tumors that have a higher recurrence score, are more aggressive and less typical. And then HER2-positive and ER-positive, and then basal-like, which is the triple-negative breast cancers. So there's this terrible breast cancer, triple-negative breast cancer, actually occurs higher in African women. And this is a study that showed that the incidence of this basal-like or triple-negative breast cancer is higher in premenopausal African American women, that specific group of women which has a little higher incidence, and this would translate to higher mortality. So there are also differences in genomics. Although this is not very completely well studied, I would say the data is very limited and conflicting. We know that there's a higher than average BRCA1 and 2 positivity in some populations of patients of African descent, and the distribution of triple-negative breast cancer varies across populations in Africa and in the African diaspora. And there's an increase in BRCA1, 2 polymorphisms and variants of unknown significance across Black women, and there are also other somatic mutations in patients with family history which are not as well studied, and unfavorable epigenetics. I would remind you that a lot of what we know about breast cancer genetics came from strong family histories in Ashkenazi Jewish women, just because there were lots of family histories to follow. And we have not studied Black women and families with cancer as well. So there are likely genes being carried down from grandmother to mother to child, or grandfather to woman to child, that we don't know about. But there is disparity of care, and some really good evidence about disparity of care has to do with different rates of breast cancer death among Black women across the country. And this is in my mind, a very stark reflection of healthcare in this country. It's the same SEER database and looks at African American breast cancer mortality between 2011 and 2001 and 2007 and 2011, based across the country. And there are some bright spots, Massachusetts, Wisconsin, and there's some bad spots where deaths per 100,000 were greater. And there's no good biological explanation for that, why it should be different by healthcare. You can imagine the reasons why there are state-to-state differences. This difference between New York and Pennsylvania, for example, what would that reason be? And I'll let you to think about it. Okay. In another study, which was also quite remarkable, remember I talked about the change in the death of, particularly in white women over time. And as you can see in different cities in the United States, those death rates, ratios changed. So in New York, we did actually okay. While there is a disparity, higher rates of death in black women compared to white women, that change did not change substantially between 1990 and 2009. But in a city like Memphis, the ratio doubled. So it went from about 1.2 to 2.1, considering that it's not that the rate of black women rose, it's the rate of white women, the death rate of white women declines way more than that of black women. And why that would be in a place like Chicago and Memphis and not Los Angeles, as much in Los Angeles and New York, leads us to ponder. So screening, so we all like to talk about screening and how important mammography is. Well, mammography has an impact on the outcome of breast cancer, but its outcome is moderate. But we do know that black women have as good participation in mammography as any other ethnic group, which talks a lot about the issues about education and access to care. If someone thinks and knows that mammography is important, they get their mammography regardless of the barriers to care. And despite that, but there is difference in the screening that women get. In one study, facilities serving minority women were less likely to be academic, less likely to be private, less likely to have digital mammography, less likely to have dedicated mammographers, and meaning a mammographer who does just mammograms, and more likely to have delays for callbacks for diagnostic workup, 26 versus 14 days on average. And this is an example, so while the patients are getting mammography, I'm not sure that the quality of care and the attention to care is as good. And there's many differences in treatment: misuse, underuse, and delay. And this, Silber and Jama went through a lot of the same data and looked at 100,000 new diagnosed invasive breast cancer patients that are greater than 65. If you're greater than 65 in the United States, you have Medicare. So again, the issues of insurance and insurance barriers to care should be less. And 7,300 were black. And they matched patients based on tumor stage and tumor biology and treatment, trying to tease out the biology part from the treatment part, or from the healthcare disparity issue. And there were substantial differences. Black patients were more likely to have delays in treatment. They were more likely to have substantial delays in treatment, more than a few weeks. Were less likely to receive anthracycline and taxane-based chemotherapies when it was indicated. More black patients presented with advanced disease. Black patients were more likely to die, both of breast disease and other diseases. So in addition to the additional mortality from breast cancer, there was additional mortality from comorbidities. Black patients, in this study, he found that black patients were asked, all these patients were asked, when was the last primary care visit you had? And black patients had fewer pre-diagnosis preventative care visits than white patients. And they were also less likely to receive treatment that follows current treatment guidelines. And also, referral for genetic testing seemed to vary. This was one study in a university hospital that looked at the referral rates, and they found that African American women with family history of breast cancer or ovarian cancer were less likely to receive genetic testing and counseling. They were also less likely to know their family history. There may be some cultural impacts. I have noticed that some patients are fully aware of their family history, but I've met other patients who do know that their grandmother died of cancer or their aunt died of cancer, but they're very circumspect about why they died, what disease they had. And minority women who had poor personal risk awareness, as well as limited knowledge base of cancer genetics. So they didn't know that it was important to have their genetic tested, the genes tested to look if they were higher risk. And this was in part an explanation for the lower utilization of genetic services by African American patients. I would tell you, in my patient population, if I refer a patient or offer a patient genetic testing, they say, yes, please. So you have to wonder whether things have changed. And So what can we do to improve care and how we can do a better job? Well, the first thing I think is to do a better assessment of ancestry and risk. I think it's really important to, rather than rely on self-reported race and ethnicity, we can use genetic markers, ancestry markers that people get from 23andMe or Ancestry.com to actually figure out where people came from, so we can figure out if you have a unique genetic risk for cancer. We could find out more ancestry-related risks. It turns out that people are really not necessarily what they say they know they are. Despite all these varying degrees of admixture, self-reports based on cultural, familial, and geographic things they know about each other, but they don't necessarily know what their genetic profile is. And while their cultural and family and how they grew up and where they grew up may influence their lifestyle and other multiple risks, it does not alter their genetic risks. And women, like we know that Ashkenazi Jewish women have increased risk of BRCA1 and BRCA2 mutations. Some studies have shown women of Afro-Caribbean heritage have higher BRCA1 and BRCA2 mutations. There was a study that looked at Hispanic women, and the more Native American admixture you had in your genes, the lower the risk of breast cancer. However, many people don't know they're Native American or overestimate their Native American admixture. And African American ancestry and African American women of mixed heritage may have a risk for triple negative breast cancer, whether they know they're African American or not. Remember, there are people who have inherited, come from different backgrounds that they're aware of. This is coming from one of our graduates from this program, Lisa Newman, and she looked at, she's been very interested in triple negative breast cancer, in particular triple negative breast cancer in Africa, and have found that triple negative breast cancer is more common is more common in women of West African origin, people from West African origin, which is a percentage of the patients that came in the slave trade, which may explain the increased rate of triple negative breast cancer in the United States on black women. And they're putting this together. We've also found that there's increased BRCA1, BRCA2 found in patients from the Bahamas specifically. But there's good news, is the NIH has recently launched a study of breast cancer genetics in black women, which will help us sort out some of these things. The other issues related to comorbidities and obesity. This was a study that looked at the rate of death from breast cancer, and they were able to find that while you're more likely to die, the more comorbidities you have, the comorbidity didn't impact breast cancer-specific survival, and it didn't explain the disparity between black and white women. Black patients were more likely to have many comorbidities, but when you teased it out, the same percentage of patients who were dying of breast cancer, more black women died of breast cancer regardless. It could not be explained by their comorbidities. How can we improve care? Maria Costaldi, who is another graduate from our program, looked at in Jacobi, implemented a navigation system, and they found that they were able to reduce time to treatment, improve compliance with adjuvant therapy, improve compliance with national quality form measures on breast cancer. So implementing a navigation system is effective and improving quality of care. Another New York group, 6 hospitals in New York, implemented basically a closed loop system where consultations were followed up on and patients were checked up if they made their appointments. And they were able to impact whether patients got to see the oncologist, got their chemotherapy, started on hormone therapy, or even to decrease the number of missed appointments. And look, I looked really hard for whether there was evidence about having health insurance, and the idea of universal health care, and whether there is evidence about the Affordable Care Act and how that changed care, and the data is very thin. We know that women without insurance are more likely to present at a later stage, are more likely to forgo breast conservation or reconstruction, and are more likely to receive non-standard treatment. However, the impact of ACA on breast cancer survival, the data is not ripe yet. One group did look at young women with breast cancer who were eligible to have health insurance based on the change, the first phase of the Affordable Care Act, and there was a 3% decrease in the uninsured rate, but no difference in time to care. I think it was a very limited study with the wrong population, and a 3% difference, I'm not sure, of an insurance rate, I'm not sure you're going to see substantial differences in care. There was an interesting study looking at the pre-ACA Medicaid expansion in New York State, which did not change overall use of cancer surgery. It just shifted the financial burden from the patient and Medicaid, and from the hospital and the patient to Medicaid and the government. And there is evidence that the ACA decreased disparities in the general measures of access to care, but not yet in breast cancer. So putting it all together, tumor biology intersects with delays in treatment and misuse in treatment and underuse of treatment to cause disparity of outcome between black and white women and minority women. And there are a whole slew of ways that we can improve that, looking both on the one side, physician communication, patient navigation, access to care, and patient and community education. And the other side, looking at clinical trials and redesigning them to look at this problem. Novel therapeutics, we need more targeted therapies for patients with triple-negative breast cancer. Genetic testing for all women, and precision medicine, where you identify a patient and look at their cancer and treat their specific cancer. And that's it.
Thank you, Dr. Dresner. It's my pleasure and an honor to welcome our next guest speaker. If the first sort of part of our agenda was dedicated to dignitaries from outside, mostly, and for people who were invited for reasons to give us a little bit more of a view from an elected official perspective, the second part of the symposium is really the people who speak are really our family from here, from downstate. And one of those people is Dr. Vadia Abulafia, who is the chair emeritus of the Department of OBGYN. I don't know of any person who is as passionate, as dedicated to care of the patients that we serve, specifically in this community as he is. We've had many discussions over the years, and I've learned from him just by having those discussions what it really means to be a caring, dedicated, top-notch surgeon, professional. I look forward to hearing from Dr. Abulafia.
Thank you so much for your kind introduction. And I'd like to thank Dr. Grusner, Dr. Moro Salifu for inviting me to give this very important lecture here. I would like to say that this topic is very dear to me, and ever since I came to Downstate more than 20 years ago, the department under my leadership delivered the best care possible for every patient, regardless of ethnic background, socioeconomic status, poverty level, et cetera, et cetera. Every patient that came to this institution with cancer and otherwise received the best care. In fact, we have a tumor board for every patient with cancer with many experts within the institution where we determine the standard of care. You will see that not adhering to standard of care is one of the main reasons for disparities in our field. That's very, very unfortunate. I'm not accusing anyone, and I'm sure many of the things that I will say were discussed here before. I think we as a society must come together, address the truth, as embarrassing as it may be, and just deliver the best care possible regardless of everything else. And I was very happy to see a quote from the Talmud, which I study, that saving one life is saving the entire world. So, one patient at a time. You are not going to be able to fix problems if you do not respect every patient, and the patient is the center of your attention. Okay. National Cancer Institute defines health disparity as differences in the incidence, prevalence, mortality, and burden of disease and other adverse health conditions that exist among specific population groups in the United States. The main reasons for disparities include geographic access and hospital-based discrepancies, disparities, same thing, research-based disparities, socioeconomic factors, and health insurance status, race, and biologic factors. In terms of geographic access, it has been established in all the fields that access to high-volume hospitals and qualified providers are factors for optimal management and outcomes in gynecologic cancers. And Bristow and Sleeby recently determined, after analysis of 96,000 patients with ovarian cancer, that only 56% of patients receive standard of care treatment based on NCCN guidelines, and 25% of women receive their care in low-volume institutions. Both factors were found to be independent prognostic indicators for poor survival, with hazard ratio of 1.33 and 1.08, respectively. Also, significant number of patients with gynecologic malignancies live in low-access counties located more than 50 miles from the nearest gynecologic oncologist, and these counties are rural and have residents with lower median income, a known factor associated with poor outcomes. In a span of about 1994 to 2013, 170 gynecologic oncology group trials were conducted in this country, enrolling 45,000 patients. I'm proud to say that we conduct gynecologic oncology group trials at this institution. I'm so glad that Dr. Choi and Dr. Wenqing Li are here. They've been helping and participating so many years. This is very, very prestigious in that only few hospitals around the nation provide these important trials. However, among these 45,000 patients, only 8% of the patients were African American, compared with 83% white women and 9% of other ethnic groups. All our patients here are minorities. And we are very, very proud of it. I'm not so sure everyone knows that, but all our patients are from this community, and we're very proud of it. And using CDC data revealed that African American patients were 15 times lower than expected to be enrolled in ovarian cancer trial, 10 times lower than expected to be enrolled in uterine cancer. Same thing with cervical cancer and sarcomas trial. And the overall decrease in enrollment of African American from 16% from 1994 to 2002 to 6% from 2009 to 2013. For us, in order to address disparities, we have to analyze biology of tumors. It's extremely important to enroll such patients around the nation. It is still very low rate of enrollment. And the main reasons for or the barriers to minority recruitment to clinical trials include lack of opportunities to participate, and of course, as I said, correct me if I'm wrong, about 50 institutions in the nation provide these clinical trials that are NCI designated. So, of course, most of the patients will have their surgeries and their treatment in institutions that do not provide this. That is why I think many people around us should know that we have it here, and perhaps we'll be able to include more patients from this community. Lack of encouragement to enroll. Some studies have shown that there was some enthusiasm among minorities to be enrolled, but for whatever reason, they were not encouraged enough, and that did not happen. There is a language barrier, of course, and travel expenses, as trivial as it may sound to us, some of these patients cannot afford to really come to the hospital, and so that's one of the reasons. Of course, There is also a trust issue. I don't have to remind you that some unethical studies were conducted in this country. And there is still a problem of trust, and we have to work on that. In terms of socioeconomic status and health insurance status, individuals with lower socioeconomic status have disproportionately higher cancer rate and death rates than those with higher socioeconomic status, regardless of demographic factors such as race and ethnicity. According to United States Census Bureau, 10% of non-Hispanic whites, 12% of Asians, 23% of Hispanics, and 26% of African Americans live below poverty level. We already said that it is one factor contributing to poor outcomes. And despite the Affordable Care Act, 17% of Hispanics, 8% of Asians, 12% of African American, and 8% of white women do not have medical insurance. These are the facts, guys. So DeSantis in 2017 determined that despite the reduction in overall cancer-related deaths since 1990s, 5-year survival for African American women is significantly lower than white women at each stage of diagnosis. And African American men and women are more likely to die from cancer than any ethnic group. And although the incidence of new cancer diagnoses per 100,000 individual is lower among African American women than white women, it's about 391 per 100,000 versus 418. The death rate per 100,000 is higher among African American patients at 180 versus 155 with the odd ratio that you just see. I'm going to talk about specific cancers. I will not be able to cover everything in my field, but I thought that the 3 main cancers I should discuss. So the first one is ovarian cancer. That's a little blurry, and you'll forgive me. But this slide shows metastatic disease of ovarian cancer in the upper abdomen. And the goal for the gynecologic oncologist, if you will, is to try to reduce the disease and remove all the cancer implants throughout the abdominal cavity, which may include bowel resection, spleen resection, and every organ, and liver resection, and so on, in order to render the patient in the optimal group. The optimal group means that at the end of the surgery, there is no visible tumor. So that's the most optimal definition of optimal debulking, in that there is a straight correlation between residual disease at the end of surgery and 5-year survival. Epithelial ovarian cancer is the 5th cause of cancer death in the United States, with approximately 22,000 new cases and 14,000 mortalities. Standard of care include comprehensive surgical staging for early stages and extensive tumor debulking followed by chemotherapy for advanced stages. Surgery should be performed by the gynecologic oncologist. Studies have shown in comparing surgeries performed by general surgeons, and I'm sure all of you are very, very good, and OBGYN generally survival is superior to gynecologic oncology. So I do not want to offend anyone. These are the facts. So it should optimally be performed by a gynecologic oncologist, because that's a special training that we receive. And okay, so the rate per 100,000, you can see that white population 11.3 per 100,000, followed by Hispanics 9.8, and African American at 8.5 per 100,000. And Bristol in 2015 reported worst survival outcome among African American population result mainly from barriers that impede access to quality care and standardized evidence-based surgical and adjuvant treatment. And according to SEER data, African American women tend to present at more advanced stages, and they also had higher comorbidities. Now, why is this so important? If you understood that part of the treatment and standard of care is extensive surgeon may not perform debulking, or the debulking will be suboptimal, and the treatment will be mainly chemotherapy. Now, chemotherapy does not work in the presence of bulky tumor. So, extremely important to remove all the cancer that is possible to be removed. And patients with comorbidities already are behind the curve. And so, for whatever reason, when you have comorbidities, it's going to be a problem with this cancer. Another study that indicated that African American race was associated with statistically significant and independent lower likelihood of hysterectomy, lymphadenectomy, bowel resection, and surgery by a high volume surgeon. These are the procedures that we do for tumor debulking. So if you don't do that, that explains why survival is not comparable. And African American and Hispanic patients were less likely to receive comprehensive staging compared to white patients. And there was also delay in administration of adjuvant chemotherapy in ovarian cancer. I do not know how to explain this, guys. And I'm not pointing fingers. These are the facts. And it's embarrassing. So at this institution, that is not the case. But it is existing and very prevalent around the nation. So another study of analysis of 36,000 patients with ovarian cancer, and 2,471 of them African Americans. Again, African American patients were less likely to receive surgery and chemotherapy, and they had lower survival compared to white women. Another embarrassing study, if you will, among 1,100 patients, 118 African American and 125 Hispanics, 66% of patients with insurance versus 54% of patients with Medicaid or no insurance received guideline treatment. And in women without private insurance, 26% of African American and 34% of Hispanics received guideline treatment versus 51% of whites. This slide shows a summary of many SEER studies in a span of almost 30 years. And you can see it covers above 10,000 African-American patients with ovarian cancer, and it shows the effect of African-American race on survival and epithelial ovarian cancer. So you can see the hazard ratio of all these studies will unequivocally show the effect of race on survival. So let me then ask a question. If we create an environment in which all patients receive the best care, standard of care possible, in a high volume hospital with a qualified surgeon, can we reach comparable survival to the white population? Fortunately, the answer is yes. This slide shows 3 studies comparing African American to white women, and is showing that there is really no difference in survival when we deliver standard of care regardless of everything else. This is good news, but it behooves us to really insist on the best care for every patient regardless of where they live, regardless of how far they are from a gynecologic oncologist. I think there are many hospitals around the nation that should really work on that and improve overall survival. So the news is, if we insist on quality of care and standard of care by qualified surgeons, we can reach very good results. So this is very interesting in that if you look at 1977, survival of African American was superior to white population. And as we move toward 2007, you can see it reversed. And initially, in In 1975, the treatment was not as complex, and we did not have so many regimens in chemotherapy. So we only had cisplatin and Cytoxan and some other single-agent drugs, and debulking was not an established procedure. And my assumption is that as the disease becomes more complex to manage, that may explain the survival differences in that you need a lot of coordination, you need very qualified surgeon to do the surgery, you need comprehensive combination chemotherapy, so that may explain this, partially. As we move to 2018, we gained about 2.5%, both for African American and for white women, at 46.2 versus 38.5. And again, there is a lot of work to be done in order to decrease this gap. That's a study by the American Cancer Society, and it shows ovarian cancer incidence and mortality rates by ethnicity from 2010 to 2014. So you can see that the mortality rate for African American is still significant compared to the other minorities. Number one is, of course, white women at 12 per 100,000, and then American Indian and Alaska Native, then Hispanics, and non-Hispanic Black, and so on. So we're going to move to cervical cancer. This is an exophytic lesion protruding from the cervix. This is invasive cervical cancer. Cervical cancer has been a success story in our field, and we are able now to reduce the incidence significantly. Unfortunately, around the world, we are expecting about 500,000 new cases of cervical cancer with 300,000 mortalities each year. Anecdotal reports in China, rural China, India, Africa, where you examine the patient the first time and you can find 10% invasive cervical cancer. That is a shame, because Western countries that adopted Papa Nicolau smear as a screening test, we have shown that we have reduced incidence significantly. And the reason is, this is probably the best screening test in cancer today. The natural course of the disease is such that it stays at a dysplastic or precancerous level for many, many years. That's where we have the opportunity to obtain pap smear, which is obtaining many, many cells from the transition zone. Now we know that cervical cancer is caused by HPV, and we have introduced also vaccination. However, we are not delivering the vaccine in the optimal fashion yet. So, in this country, compared to the world, about 13,000 new cases and 4,000 mortalities. And as I mentioned, significant progress has occurred in countries that adopted Papa Nicolau smear. I hope, and I may be naive, that the technology here for HPV vaccination will be shared with the rest of the world. Maybe wishful thinking. It's all money, but if we are going to vaccinate all the adolescent girls and boys very early on, before they become sexually active, we are going to be able to eradicate this disease. I believe in that, and remember that 99% of cervical cancer are because of HPV. So if we control HPV, we'll be able to control this disease. Treatment include radical hysterectomy or Vertime for early stage disease, and radiation therapy in addition to chemotherapy for advanced stage disease. And as I mentioned, despite availability of tested screening tool, African American and Hispanic women are more likely to be diagnosed with this horrible disease. So that's the rate of new cases. And as you can see, Hispanics have the highest rate, followed by African American and white population, white women. There's a lower rate of HPV vaccination African American and Hispanic adolescents. There's been enough enthusiasm by minorities to participate. For whatever reason, they do not finish the course of the vaccination. And we have to work on that. Even here, we did not reach the optimal level of vaccination. So we should all work together, and the medical students who will be family practitioners and some other disciplines, please be sure to remind people that you will take that this is so important to do. We are going to eradicate this disease. Breast and Cervical Cancer Mortality Act was passed by Congress in 1990, and that resulted in 85% of African American women receiving pap smear in the prior 3 years. However, they were more likely to be lost to follow-up. Now, when you have abnormal pap smear, that should trigger colposcopic examination, because pap smear is a screening test and it's not diagnosis. You have to confirm with histologic, with biopsy, via colposcopic examination. And if a woman comes to her doctor and has a pap smear every 2 years, 3 years, even 5 years, there is a very good chance to find this disease when it is in the dysplastic phase, where we can cure almost 100%. Once it breaches the basement membrane, that's a definition of invasive cancer. That is where it can reach vessels and lymph nodes, and survival decrease significantly. So again, African women were less likely to undergo radical hysterectomy than white women. They also were less likely to receive intracavital radiation. Intracavital radiation, I'm glad Dr. Choi is here, delivers very high dose radiation to the tumor itself. And the combination of external beam and brachytherapy, we call it, can really eradicate or can really give significant survival now with the addition of weekly chemotherapy or weekly cisplatin. And of course, access to adequate cervical cancer screening and preventive care remains critical in eliminating racial disparities. That's another study that is embarrassing. Farley in 2001 used data from a central tumor registry for the United States military healthcare system. Between 1998 and 1999, there were 1,500 patients with cervical cancer, and among them, 29% they were treated according to standard of care. And look, the results show unequivocally 5 and 10 year survival rate of 75% versus 76%, 64 and 65, respectively, with a non-significant p-value, concluding that equal care ensure equal survival for African American diagnosed with cervical cancer. So that's the current 5-year relative survival. You can see among whites 68.9, African American 57.7, and the others include all the other minorities. Most of the literature pertains to African Americans. That is why my lecture is more toward this ethnic group. This is a lesion inside the uterus that is invasive endometrial or uterine cancer. That's the most common gynecologic cancer in the United States, with 54,000 new cases and 10,000 mortalities. For all stages, 5-year survival is 82, as high as 95 for stage 1 disease, 68 for regional disease, and 18% for metastatic disease. The treatment here also includes surgical staging for early disease, followed by tailored radiation therapy and extensive tumor debulking, followed by combination chemotherapy. And similar to ovarian cancer, it's preferable to have the gynecologic oncologist operate on the patient and deliver care. In terms of new cancers, white women will have 27 out of 100,000, and immediately after, African American at 26.6. Similar to ovarian cancer, the several studies attributed a significant difference in survival to inequality in access of care, again, adherence to evidence-based treatment guidelines, and socioeconomic barriers. A report from the Health Disparities Task Force of the Society of Gynecologic Oncology in 2014 indicated that unlike ovarian cancer, there may be an inherent difference in tumor biology between whites and an African American patient, as equal treatment has not correlated with equal outcomes. So this tumor is a little different than the other two that I discussed. African American patients tend to be diagnosed at higher stage, higher grade lesion, and higher risk histologies. And although worse tumor characteristics are associated with worse prognosis after accounting for all histopathologic and socio-demographic factors, several large database analyses again demonstrated worse survival associated with African American patients. In terms of biology of the tumor, even with stage 1 disease, it's supposed to give better survival, P53 mutation was more common, 3 times more common in African American patients compared to white patients. And AGR2 or HER2, a new expression in serous cancer that is also a very aggressive tumor, was also higher among African American. And unfortunately, even fewer PTEN mutation for endometrioid cancers that portend good prognosis were fewer in African American patients. So another randomized studies by gynecologic oncology that clearly states that, and that's a randomized trial, that despite similar treatment, worse overall survival persists among African American women with uterine cancer, and they have 26% higher, greater chance of death compared to white women, despite similar and surgical chemotherapeutic treatment. That's the current relative 5-year survival. As we can see, for whites, 82%, for African Americans, 60%, and for the other group is 82%. I'm sure that some of that disparity has to do with biology, but not everything. We really have to work very, very hard to decrease this gap. I would like to conclude and say that health disparities in gynecologic oncology persist and are worsening in some cases. Multiple factors, which include racial, economic, geographic, biologic factors, and influence treatment and survival disparities. Evidence suggests that equal care results in equal outcome for women with ovarian and cervical cancer, but differences in tumor biology may partially explain disparities in uterine cancer, and we do need research into intervention that effectively reduce these documented disparities, and we need it urgently. Thanks for your attention.
All right, so Francesco and I are going to do the duet now.
He's the only one that's going to do the singing. I'm gonna just.
Okay. It's my pleasure to introduce again one of our own family, Dr. Serafini. Dr. Serafini is the Chief of Surgical Oncology at the
Okay, thank you very much. This is a very kind introduction. It is true. I'm a much better sailor and a cook compared with a surgeon. So, Dr. Schwartzman asked me to talk about gastric cancers and upper GI cancers, essentially. So we kind of finalized the issue with talking about gastric cancer and GIST. So this presentation will be about the general overview of the disparities reported in the literature for gastric cancer, and a little bit more local experience with GIST tumors. Okay, so gastric adenocarcinomas and GIST. So gastric cancer, as the slide says very well, it's a different disease in different areas in the world, in different ethnicities. It is true. And that has been shown in many, many studies. Essentially, the biggest disparities are between the Asian world and the Western world. Despite a little bit of a downtrending, still gastric cancers are a main cause of cancer-related death. In the world, it is estimated about 1 million people get a gastric cancer every year, and close to 700,000 die. A lot of those gastric cancers, they're still in Asia. The overall trend in the United States, for many reasons, is toward downtrending. Despite of that, there's a lot of people getting a gastric cancer in the United States. There's about 20,000 gastric cancers in the United States every year, and about half of those will die. The disparities in gastric cancer are at all levels. They are on the epidemiology, the biology, the stage of presentation, the grade of the tumor, the type of treatments that patients get if they get a gastric cancer in Asia or in the United States or generally in the Western world. And definitely that translates into a different survival. So I figure for the next slides, I set up some bullet points, particularly for the resident staff, just to show you the disparities among populations with the gastric cancer. So this is these are data from the Global CAG, which is it's an epidemiology organism that studies the incidence of different type of cancer throughout the world. And this is the incidence per 100,000 people. As you can see that there's nations where gastric cancer has a very low incidence, 3.1 in Egypt, where in Korea it's about close to 70. Can you imagine that? I mean, it's like the flu. It's very, very frequent. It's endemic just about. Italy is somehow in the middle, and same thing for the United States. Probably United States a little bit less than that. These are data of the difference in the ethnicities in the United States. These are data related to stage migration, such as Asian population migrating from Japan, Korea, China into the United States, preserving that high incidence at least for the first generation. So you see that Asian population, male 21 per 100,000, definitely higher than what it is for Caucasian. So after the first generation, it has been noted that this incidence drops. So those patients, they don't go to the same incidence, they don't reach the same incidence of gastric cancer as the Caucasian population, but they go pretty close to it. So disparities and differences also in the risk factors. Smoking is more prevalent in Asia and also in the United States population among African Americans. Food, also disparities over there. Very salty food and food with more preservatives among the African American population. H. pylori, which is essentially has a very low incidence, or at least is very well cured in our population, in the Western population. It is endemic in the Asian population, in Japan, in Korea. And also there's a lot of genetic factors in the Asians. And obesity and smoking, as well as a problem for the Caucasian, mainly white population. So H. pylori also has a different type of characters if it occurs in Asia or if it occurs in the Caucasian population. For example, there's a strand, which is the CAG-A, a strand which is much more prevalent in the African American population, portending to a worse outcome in those patients with gastric cancer. And as well, those different risk factors that we just spoke about, they do translate in different location in terms of gastric cancers. So if we have more distal cancers in Asia, we have more proximal cancers in the Caucasian population in the United States. And in contrary to the general downtrend for all gastric cancers, the proximal cancers are actually increasing. They're actually 40% up in the last 25 years. So, all gastric cancers, they have in common as risk factors age, male sex, smoking, and some family history. Now, the more proximal cancers have in common obesity and gastroesophageal reflux disease, which are diseases of quote-unquote wealthier populations, such as the Caucasian, mainly white. On the other hand, the distal, they do recognize as specific risk factors, the H. pylori infection, the low socioeconomic status, and some form of diets. Therefore, Asians will have more distal cancers. Caucasian, as I said, more proximal. Hispanics and Asian, they will have more distal cancers. And as I said, the proximal cancers are increasing. There's also disparities in terms of tumor biology. Microsatellite stability is more prevalent in Japanese patients, portending to a better survival. As well, the expression of some adhesion molecules, like E-cadherins, is more frequent in gastric cancer from Asian people, having a better prognosis. CERB2 is more prevalent in the Western Caucasian population. That's why those patients, they may experience worse survivals. The chemosensitivity is also different. Asian patients, they express more these genes, and they seem to be more sensitive to chemotherapy compared to the Caucasian population. So a lot of disparities. This is today you have heard the SEER database word from everybody that has given a talk. Well, everybody, looks at the SEER database to look at trends and incidence and data. This slide shows that patients living in the United States from Caucasian ethnicity or Asian, they do have significant differences in terms of stage of presentation. Stage 1 and Stage 2 are much more prevalent in the Asian population, and also in the grading, which is more favorable in the Asian population, and also in terms of size of tumor. So they have a more favorable type of tumors in general, Asian patients, even if they migrate into the United States. Also, the type of treatment that patient will get across the world for gastric cancer, they do differ. For example, because of the screening protocols that they are present in Asia, in Japan, imagine that they do screen patients for gastric cancer like we screen for breast cancers. They actually have mobile units that perform endoscopies almost like taxi cabs in the street, really. So they're very organized because that disease is very prevalent. So more patients will present with earlier stages, and more patients will be amenable to smaller type of treatment, more or less invasive treatment. EMR and ESD essentially were developed in Japan, and they essentially are the base of at least 30% of the procedures done for gastric cancer in Japan. On the other hand, we do very little of those, not only because we're not as good as they are, and they are probably the best, but because our gastric cancer here, we don't do any screening because there's no need to do any screening, are usually discovered at more advanced stages. So the operation that is essentially performed here, except for those sporadic T1A cancers, essentially either is a subtotal or it's a total gastrectomy. So significant difference in terms of treatment. Again, differences in treatment for whatever comes along with the treatment of the primary tumor. The lymphadenectomy, this has been a debate, a huge debate for years, a matter of debate between the Asian surgeons and Western surgeons. In England, there was a very large study. They published a very large study from the Medical Research Council about the validity of that famous or infamous D2 dissection, lymphatic dissection, that the Japanese authors are proponents. In England, they were not able to reproduce the advantages claimed by the Japanese surgeon by doing a extended D2 lymphadenectomy. Some advantages were reproduced by a later published Dutch study, but not as much as what the Japanese authors they claimed. And if you can imagine that for some of this procedure published in the Dutch study, there were senior Japanese surgeons that traveled from Japan and assisted the surgeon in performing those procedures. They were not able to reproduce the same data. On the other hand, Japanese patients and the Japanese surgeons, particularly the Japanese surgeons, are proponents of this extended type of lymphadenectomy, essentially not only limiting the removal of the lymph nodes to the stomach, but also go beyond that to the celiac trunk, hepatic artery, splenic artery, essentially what we do here. We do a formal D2 dissection in all our patients. Japanese surgeons claim that European surgeons or American surgeons are not as good as they are. They haven't standardized their technique, and that D2 lymphadenectomy should be the standard of care. So disparity also in the form of treatment. All these disparities, and we don't know which one to point out to, but all these disparities, they do contribute to a significant difference in survival. So this is a very brief slides with very raw data, but it strikes that the 5-year survival, overall survival of a Japanese patient with adenocarcinoma is 65%, and European and United States patient instead it's less than half. So, okay, this is another slide that shows you how different is the stage-by-stage survival between United States and Japan. Again, differences in the T-stage presentation and the survival according to T. Similar T in different population will have different survival, and this is a statistically significant difference. So in conclusion, as far as it concerns gastric cancers, there are significant disparities, and those disparities are mainly between Asian population and Western population, including Hispanics, African American, Caucasian, and they're multifactorial, related to risk factors, biology, type of treatment, screening, and incidence of the disease. So there isn't a real single factor that we can pinpoint to determine what will make the difference to make our survival better, or at least comparable to Asian patients. So the next portion of the talk is about GIST tumors, and for this, rather than talking about data in the literature, I decided to use some of our data, which are preliminary data. They're part of the data that we are accruing and we're looking at essentially at Kings County Hospital, and this is related to GIST tumors. Before coming to Kings County, to Brooklyn essentially, I mean, yes, I saw some GIST tumors, but not that frequently. After I came here, it looks like everybody's got a GIST tumor. It's like an epidemic. And by working at Kings County and at SUNY, we are frequently, oftentimes, confronted with the African American, and particularly with Afro-Caribbean population. So these are the data from 2008 and 2015. This is about a 7 years interval. Related to the care rendered to these patients in a safety net hospital affiliated with a major medical center in a large metropolitan area. In patients that are essentially of low socioeconomic status. This is our population. These are the data on 66 patients. Since this is a portion of our experience, we have done more than 100 GISTs. We have resected more than 100 GISTs, and but we have data. We have looked at data only on 66. The majority are Afro-Caribbean. We do render care. We do provide care. The patient coming from all over the Caribbean, Haiti, Trinidad, Jamaica, all the Caribbean country. And this is a slide that shows you where they come from. The demographics are similar, small difference in age, mean age between African American and Afro-Caribbean. The majority of those, 85%, are of low socioeconomic status. They have no insurance or Medicaid. A lot of those, the great majority, are immigrants of some sort, legal or not legal. And this is the way they present to our hospital. Pain is the most frequent symptom. Anemia it is. And that tells you that the stage of the disease, pain and anemia, it's pretty far advanced at the time of presentation. I'll show you later slides where we compared our data with European and Caucasian patients. So lower GI bleeding, nausea are less frequent than the other two. The most frequent site is the stomach, and followed by the small bowel. And a lot of those patients underwent surgical resection. No difference between the two groups. The tumor size, the medium tumor size, quite large, particularly if we compare it to the European and other American patients. These are some of the pictures of those tumors, some of the specimens. This is a gastric cyst resected laparoscopically. This is a gastric extended into the duodenum, invading the duodenum and the head of the pancreas, which require a little bit of a larger operation. This is a small intestine gist. This is the gist. Sometimes they do invade more than an organ, so we have to do multivisceral resections. And this is how we assess the severity of this tumor with the NIH risk category classification. And this is our patients. This is how our patients stratify according to that classification. So a lot of those are stage 3 and 4. So when we compared our data to the European and American, there was not a lot of difference in terms of the site of presentation and the median size of the tumor, but there were statistically significant differences in all these aspects. There were differences in the symptoms, how many people got resected, and also the presence of metastasis at diagnosis. Again, there were significant differences at all risk category stages for patients, between our patients and the European patients. The same differences apply to the fact that our patients did not get adjuvant therapy as much as the European and American. And also, of course, that translated in a much worse survival. But also, when they were able to get that therapy, the survival wasn't as good. The overall 3-year survival was definitely worse compared to the European and Caucasian patients. In general, they experience worst outcome. So, worst outcome in the patient with GIST in our population are related to a lower socioeconomic status, but also more likely than not to a different biology of this type of tumors. So this concludes my presentation, and then I guess I'll see you on the QA session. Thank you very much.
Thank you, Dr. Serafini. Next speaker is Dr. Schwartzman, and he will talk about disparities in the treatment of pancreatic cancer.
In terms of the incidence worldwide, this is now North America, and that includes, of course, also the Canada and Mexico. The incidence is a little bit higher with the pancreas, probably at around number 15, number 13. United States, it's still a little bit higher, probably about number 12, and this is again the incidence. This is the data from the NCI, and it places the pancreatic cancer at about number 12. What's interesting to notice is the overall incidence of cancer of pancreatic cancer is only 3.2. Yet if you look closely here, it's the number of deaths is 43,000 and the incidence is 53,000. So you can see how deadly the disease is, and we're going to see exactly the numbers in terms of the frequency. This illustrates it very nicely, where the pancreatic cancer is number 12 in incidence, and this is in the United States, and this is already anticipating the results of 2018, so this is this calendar year. And if you look at the number of deaths ranking, it's going to be at number 2. So it was anticipated that the pancreatic cancer is going to be probably number 2 for deaths related to cancer by the year 2020. Some literature was saying that it's going to be in 2030. However, it is already anticipated that in 2018 it is going to be number 2 cause of cancer deaths in the United States. This is a very depressing and telling slide. This is very similar to what Dr. Grusner had shown in the beginning of the presentation, where the 5-year survival rate is only approximately 7 to 8%. So why is it so different than all the other cancers? Well, we have the tools that we need for screening. The patients become symptomatic even, and we are able to make a difference in these patients' lives. However, not really in pancreatic cancer. If you look at the colorectal cancer, the 5-year survival rate is going to be 64%. In breast cancer, it's 89%. And in, of course, the pancreatic cancer, it's only 8%. Again, the patients present late in the course of the disease. They have no symptoms. By the time symptoms develop, even in the early lesions, and I know that this is not the subject of this talk, but even for T1 patients, the results are not as good as we would like to see them in other tumors, and this is especially related to the tumor cells that are already circulating in the bloodstream, even in patients who have T1 disease. So this is to emphasize no effective screening. Patients present usually late in the course of the disease. Now let's talk about the risk factors. And there are some risk factors that are inherited and some risk factors that are not inherited. And although this seems like a very high incidence with hereditary pancreatitis, as you can see, the risk of developing pancreatic cancer is 52 times the chances of developing pancreatic cancer in a patient who does not have hereditary pancreatitis. And if you go just down the line, all of these diseases, as you can see how more frequently the pancreatic cancer occurs in this patient's population group. I did not really include the incidence of these diseases because it's very difficult to anticipate, even after I try to understand based on the review of the world literature exactly what is the frequency of this disease. But I was able to get it for hereditary pancreatitis. In white newborns, the cystic fibrosis is seen in 1 in 30,000. In other racial ethnic groups, it's seen significantly less. In terms of non-inherited risk factors, and here this is where it's going to be really, really important. From the perspective of smoking, it's 1.2 to 2.5 increase in risk of pancreatic cancer. Although it seems significantly less, let's say, than compared with Peutz-Jeghers syndrome, however, there are so many more patients who smoke than patients who have Peutz-Jeghers syndrome. Just to give you an idea, if you take the number of smokers in 2 most populous nations in the world, and that's India and in China, the number of smokers is probably exceeds the total population of Europe. So it just gives you an idea how many people smoke. So let's go actually specifically through various of these risk factors. Also, there are so many things that are wrong with this particular slide, and it refers to old ads with women and men smoking. You can read yourself what it says on each one of them, and there are really so many wrong things about it. But just to give you an idea, 26% of pancreatic cancer in men are believed to be related to smoking. In women, it's even higher than that. Unbelievable statistics. About a quarter of patients that we see with non-inherited risk for pancreatic cancer are smokers. The median age of diagnosis for pancreatic cancer is much earlier than in patients who do not smoke. Just because of this frequency, and this is going to be one slide that relates to some of the reasons that are believed to cause the pancreatic cancer in smokers, the nicotine itself and its byproducts are seen in pancreatic juice, in pancreatic duct, if sampled, to the order of 7 times more than, obviously, people who don't smoke. In other words, it gets really concentrated. In lung, it gets concentrated in the pancreatic juice. And just to look at this, it's 250 compounds are harmful, and 60 of them at least are carcinogenic. And one of the theories of how this occurs is believed to be that all these toxic compounds in the pancreatic juice stimulate cell activity, and that produces stimulation in pancreatic and stellate cells. It causes inflammation and fibrosis. Inflammation and fibrosis causes proliferation, apoptosis, inhibition, and invasion, and this produces pancreatic cancer. Diabetes. Both type 1 and type 2 diabetes have double the risk of pancreatic cancer. At least about 10% of patients with pancreatic cancer will have disease that is pancreatic cancer that is attributable to diabetes. If you look at the variable where it says in red, compared with the age-major general population, subject older than 50 years who have newly developed diabetes have at least 6 to 8-fold higher probability of being diagnosed with pancreatic ductal carcinoma within 3 years of diagnosis. So that means that the patients who just develop diabetes, we have to watch them exceedingly carefully. They are at a very high risk for developing pancreatic cancer. Obesity. Obese patients, 2 times the risk factor of patients who are not obese to have developed pancreatic cancer. Physical inactivity is another thing that is linked to developing of pancreatic cancer. Consumption of large amounts of red meat is attributed probably to a very significant number of obesity, and probably about 12% of pancreatic cancer in men and 11% in pancreatic cancer in women. If the consumption is reduced to low amounts, that immediately has an effect of producing 30 to 45% chances of lowering the incidence, and those who are on vegan or vegetarian diet, it reduces it in half. This is also just a slide that reflects on overweight, obesity, and mortality from cancer, and this is specifically related to, of course, pancreatic cancer. You can see the effects, how it affects. If you can see on the left side, it's the men, on this side, it's the women, and you can see how the progression of the BMI increases the risk factors for developing specifically pancreatic cancer. So in someone who is BMI between 35 and 40, the incidence of cancer is on average 1.49. And in females and males, it increases it tremendously as well, as you can see. Well, the good news, the first item, moderate alcohol amount, is not associated with increase of pancreatic cancer. I'm saying it's because it's close to 5 o'clock. However, there is an increase of risk of pancreatic cancer with heavy alcohol consumption, and that's 3 or more drinks on a daily basis. There is a very complex relationship between smoking and alcohol consumption, where one is believed to potentiate the other. However, these relationships are not clearly established. As we discussed in hereditary pancreatitis, that's the bottom item, 50 to 60% chances of pancreatic cancer, but chronic pancreatitis, which is related to whether it's alcoholic pancreatitis or whether it's gallstone pancreatitis, also has a chance of developing pancreatic cancer. Age, not that it's a risk factor, because it's what it is. However, we need to remember that it's very unusual for a patient to develop pancreatic cancer unless it's the patients with those hereditary conditions before the age 40. And most, about 80 to 85% of pancreatic cancer we see are listed in patients over 55 years of age. So this is something that really is not discussed very frequently, is not talked about very often, and that's vitamin D axis. It was found that in patients who are African American descent, the levels of vitamin D are probably 30 to 40% less than in Caucasians. How does that exactly correlate with pancreatic cancer is unknown, but there are studies that actually document decreased amount of vitamin D and exposure to sunlight in populations that have higher incidences of pancreatic cancer. So that is obviously going to be something that we're going to have to watch out for in the future. And if you remember anything, it's this Venn diagram. It's this diagram that indicates basically that it's this combination of age, substance abuse, metabolic syndrome, and that's related to diabetes, obesity, lack of exercise, and right in the middle there is the solar radiation and specifically lack of exposure to sunlight that places a particular person at the highest risk for developing pancreatic cancer. And I want you to remember this. I'm going to come back to this diagram in a little bit. So this is us. This is just for us to understand the counties where we are, the New York, the Brooklyn. And this is age adjusted by a percentage of adults overweight or obese. And if you look here, let me come on the side because it's going to be easier for me, otherwise I can't see it. Okay, so we are not the worst. If you look at the County of Kings, which is here, there is a big blue line on top, and that's the Bronx. So we should feel good about ourselves. We are not as overweight or obese as people in the Bronx, but we are substantially more so than people in New York, and New York means Manhattan. Age-adjusted percentage of adults who did not participate in leisure time physical activity in the last 30 days. That means couch potatoes. They don't do anything. Okay. So the County of Kings, 27%. So 30% of those around you don't do anything. Okay? They sit and watch TV. And remember, all these are risk factors for developing pancreatic cancer. Okay. Diagnosis of diabetes. And here we are in the blue, just below the Bronx. We are at 13.3. So that means 13.3% of population in Brooklyn have diabetes. Okay? And smoking cigarettes, something that I would never do. In the County of Kings, we are not horrible here. It's 14.8%, and we are not much worse than in Manhattan. But still, remember that Venn diagram. I'm going to show it to you again. We are very high in our community in terms of not the substance abuse, but the smoking. We didn't discuss alcohol use yet, but in terms of diabetes, being overweight, being couch potatoes, we are very high up on the list. And please remember this diagram. Okay, this is a very interesting website, and I can make it available if you'd like. You can actually go to this website. It's European consortium that developed it, and you can actually plug your information. It gives you risk numbers of possibility of having a particular cancer. Very interesting. Okay, pancreatic cancer incidence and death rates, and this is again from the SEERS data, which we have referred to it. Lack of screening tests or other early diagnostic procedures for pancreatic cancer results in uniformly late diagnosis and shortened survival time, and the 5-year is what we already stated it to be. So in terms of getting to the core of our discussion, and that's the disparities between various socioeconomic and ethnic groups, the US began monitoring cancer outcomes in 1975. Blacks have been diagnosed with pancreatic cancer at close to 50% higher rate than whites. Blacks died from the disease at 37% higher than whites. And as you can see, all the statistics, specifically for black men, are much worse statistically than for any other age group. This is specifically the numbers. This is very good statistics available from actually from the Department of Health. The only problem with that is none of the New York data has ethnic breakdown of the patients. The SEERS data goes with that. It does give you different ethnic groups. However, New York was never included in the SEERS data, so we don't have that degree of granularity. However, you can see, so we don't know. So looking at Brooklyn, this is the incidence. This is the incidence of pancreatic cancer in each borough from 2000 to 2015. And you can see that, for example, for 2015, there were 374 cases diagnosed in Brooklyn. However, we have no idea what is the ethnic background of the patients who actually developed it. But certainly, also you can see that it's the most numerous amongst all boroughs, 377. On Staten Island, 82. And this is, of course, I'm referring only to 2015, 333 in Queens, etc. So in between, in terms of incidence, in between Brooklyn and Queens, we have probably the largest number of pancreatic cancer in New York City. This is mortality rate for the same time period. You can see that in Brooklyn, 285 patients died of the disease in 2015, and in Queens, 243. Again, we see a very large number of patients in Brooklyn and in Queens who died of pancreatic cancer. This is the Sears data. It's a similar chart to what Dr. Dresner used for breast cancer. And you can see that patients who are Black, and these are the triangles, the incidence of pancreatic cancer and the death from pancreatic cancer far exceeds that of non-African American population. So this is Sears data, and although it doesn't really apply to New York, it does give us significant information about some of the things that I had demonstrated in a different slide before. And you can see, and you have 1975 to 2005, so this is a significant time period where the total, this is the table for the incidence. So the incidence is 11.5 for 100,000. However, for white males, it was 13, and for Black males, it was 19. So you can see a significant increase in incidence between Black and white counterparts. For females, it's really the same thing. The significance is quite, it's 9.7 for females, for white females, and 14.9% for Black females. This is the mortality. Mortality reflects the same thing. As you can see, in white females, the mortality per 100,000, it's 8.9, and for Black females, it's 12.5, and for white males, it's 12.4, with significant increase in mortality in Black males. Well, this is great information that we have available to us from Robert Wood Johnson Foundation. This was referred to by Dr. Easterling in the beginning of his talk. And this compares different counties. Different counties, you can compare us to any county on the West Coast or anywhere else, but I decided to, just for a reference point, to compare Brooklyn to Manhattan. So this is the numbers for the New York State. This is New York, Manhattan, and this is Brooklyn. And these are all the things that actually are measured in this database. Premature death, and this is the number of years lost. We are number 24, and 7 is, so 1 is excellent, and there are 62 counties in New York State. We are number 24. For poor or fair health, this is not self-assessment, this is based on the physician's input, 18% compared to 15 in Manhattan. Poor physical health days, this is self-reported, where people stayed home for 3.6 days out of a month, and poor mental health, 3.9 days out of a month. We're not going to go over the low birth weight. Okay. Adult smoking. We are number 52 out of 62 counties. Okay, so 15.9% smoke. Adult obesity. 23% of Brooklyn is considered obese. Food environment, which means access to healthy food, where 10 is the best and 1 is the worst. We are 7.4, number 52. We do have access to exercise opportunities. However, as we've discussed before, very few of us take opportunity to actually exercise. Excessive drinking, okay, here we are much better. Okay, so we should be very proud. Okay, and sexually transmitted diseases, this is not the top subject of this talk. Okay. Uninsured population, 8% in New York versus 10% in Brooklyn. This is very telling. Primary care physicians, 730 patients or persons for one doctor. In our neighborhood, it's almost 1,600 per one. What are staggering statistics. For dentists, 570 to 1 versus 1,600 to 1. Mental health providers, 130 per person versus 530 per physician. Okay? Look at this difference, almost 4 times. It's not that people in Manhattan have more psychological problems than people in Brooklyn, I'm sure. Although maybe if you watch Woody Allen movies, we'd disagree. Diabetes monitoring, 85%, so we're actually pretty good at diabetes monitoring since we have it so much. And mammography screening is approximately the same. Uninsured, and again, look at this, we are number 52 overall. Oh, sorry. High school graduation, about the same as Manhattan, and you get the point. Physical environment, air pollution, not bad, although we're 53 out of 62. Severe housing problems, driving alone to work, 18%. I don't know if that's a bad indicator or a good indicator. I'm not sure what that means, but for some reason people measure it. Okay. So, sex, race, ethnicity, marital status, and insurance status, how do they affect survival? And in terms of the stage of presentation or receipt of treatment, are these independently associated with outcomes is the next question. Historically black patients have been less likely to undergo resection than their white counterparts. Black patients diagnosed as having local regional pancreatic cancer were less likely than white patients to be seen by a surgeon, and black patients less likely to undergo resection if they did visit a surgeon. That indicates persistent racial balance. And this actually, next slide, demonstrates it very clearly in a nice table. I'll summarize these findings. If you look here, this is actually the patients who get to be resected, who go to the doctors and get to be resected. And what is the significance here? The males are more likely to get resected. White persons are more likely to get resected than any other group. There is non-Hispanic are more likely to get resected. And if you are married, you're much more likely to get resected. So that means that our spouses are really taking good care of us. Of course, it deals also with the ability of a person to take care of themselves after the surgery. It's not just that somebody makes you get an operation, it's the availability of someone to help you afterwards that's important. In terms of the region, good news. In the Northeast, that's probably the highest region in the country that you actually are going to get the resection. And insurance and non-insurance, interestingly, had no significant difference. So whether a person is insured or uninsured didn't make any difference in terms of ability to get a resection. So this is just, again, that slide demonstrates you're getting to the doctor and you're getting an operation. So what is it that's going to get you an operation? The next slide is going to show you what is the only real difference that affects the survival of the patient. And that goes to the location slide that I had in the very beginning. And it's actually the only thing that made the difference in lessening, in lowering the death rate, is where you had an operation. The only thing, practically. And that was having the surgery in the Northeast. okay? This is actually an extremely important slide, I think. So none of the, whether it's a person is a female or male, well, maybe there's a little bit of a significance here, but that didn't make much difference. It didn't even make a difference what ethnic group the person was. Single versus married, just because somebody got you to do the operation didn't make you healthier. And all the other things had very little difference, except having the surgery in the Northeast. So that's something that we need to advertise to everybody. Okay, in terms of the strategic approach for the future, this is still a horrible disease. This is a disease that has a survival rate of 5% to 7% in 5 years. And the point is, we don't, although we have a somewhat of an understanding who is at risk, by the time we get to these persons, we seem to make very little difference. There is an organization called Cancer Family Research Foundation, and they sponsored a conference on research in pancreatic cancer. It was hosted, I think, in 2016 in Hawaii, and they produced this slide that looks more something from, auto manufacturing, but it basically illustrates something that this is where we need to go. Number one, you have to have leaders. You have to have people who are going to advocate for what it is that is going to drive this problem, at least towards some kind of solutions. Then you have to have organization, structure, business planning, funding. We have to have philanthropy. We have to have support of organized pharma that is going to make a difference. And of course, the research. And it's a very important foundation, and we can all sort of look at their mission and see how all of us, or any of us, can contribute. This is what's in the pipeline. Anything that, any new biomarkers, it's believed that it's going to take up to 10 years to develop new biomarkers. Validating promising existing and new biomarkers, it's another 1 to 3 years. Assembling a prospective high-risk cohort for sporadic pancreatic ductal cancer, another 10 years. And initiating a prospective screening study, it's another 10 years. This is called the Sieve Approach, which is or they also refer Sieve because it looks like a sieve, and it's DEF. It's define, enrich, and find. Define the risk population, and I want you to remember that Venn diagram that I showed. All of us have to remember the patients who are smokers, overweight or obese, those who do not exercise, those who have diabetes. And of course, these are non-hereditary issues, okay? So remember those patients, and these are the patients that we are going to define as the population at risk. Once you identify the population at risk, then you can engage these patients in getting them to get the phenotypes, serological biomarkers, non-invasive imaging, and I'm not going to really go into detail about the US, MRIs, CAT scans, etc., but I'm talking about just defining the population at risk. And of course, if you do find an early lesion, then you can actually go ahead and do something surgically meaningfully about this. So before my very last slide, this is the slide, and that's why I mentioned Hafiz. And you carry all the ingredients to turn your life into a nightmare, don't mix them. You carry all the ingredients to turn your existence into joy, mix them, and mix them. And this is the last slide, lifestyle modifications. That's the only thing that we can do meaningfully to us and to our patients in terms of lowering the chances for developing pancreatic cancer. And that's control of smoking. Obviously, this is a huge population in the United States and worldwide. And every time you see a patient who smokes, tell them stop. It takes on the average about 5 to 7 times for a person to stop smoking until they actually do, if they do. But at least we owe it to ourselves and to our patients to tell them about it. Eat less red meat, we all know that stuff, right? I'm not gonna go. Exercise, control diabetes, and even control of the diabetes. Those patients in whom diabetes is well controlled, the chances for developing of pancreatic cancer is less than for those who do not have a well-controlled diabetes. prudent, well-balanced diet, limit alcohol use, chemo prevention is questionable, screening, and of course we didn't even go into any of the parts about the cystic neoplasm of the pancreas, but certainly those require an address if discovered in a very expedient and aggressive fashion. And at this point I will stop. Thank you very much.
Thank you, Dr. Schwartzman. I must say I'm getting a little bit depressed after Dr. Abulafia's talk on ovarian cancer, Dr. Serafini's talk on GIST and stomach cancer, and now Dr. Schwartzman's on pancreatic cancer, because the only remedy that we have seen so far is to stop smoking and drinking, and for many people that clearly means a severe cut in their lifestyle. Our last but not least speaker is Dr. John Renz, who joined us recently. He's going to talk about disparity in the treatment of liver cancers, and this is really the only solid organ cancer where we have a true alternative. So welcome, Dr. Renz.
Thank you so much. This is the third time I've been in this auditorium, and each time I've been last. So I've gotten very skilled at developing a light talk and a heavy talk. And since we're running a little bit late, you'll get the light talk. And I always preface it by, fasten your seatbelts and prepare to go to afterburner, because we'll just kind of go through this and get you somewhat back out on time. So I have nothing to disclose. So, why discuss liver cancer? And the reality is, interestingly, liver cancer is one of the few cancers whose incidence and prevalence in the United States over the last 2 decades has actually been increasing. And with that, the overall mortality has minimally changed. So that's a bad scenario where you have an increasing incidence and prevalence with a relatively stable mortality, and that number is very low. So for that reason, it has drawn particular attention from the NIH and the Department of Health and Human Services, who have tried to make a concerted effort at changing that scenario, and even the pointer is tired. So they've been prioritizing research funding for hepatocellular carcinoma. Now this slide basically shows you what the last one did. In light green, you see the overall new cases for the last 2 decades. And in dark green, you see the overall US mortality. And this is SEER data, which we've seen all day. It's a wonderful database, actually. And what you can see here is that when you look at the estimated new cases in the United States, it's about 40,000, but 30,000 people will die of liver cancer. And the overall survival rate for all comers who have liver cancer is under 20%. So basically very dismal results on the surface. When you look specifically at mortality, when you look at estimated new cases, liver cancer comes in at 13. But if you look at the annual mortality figure, actually liver cancer becomes 4, right behind lung and breast and colon. So lung, breast, colon, then liver. So it's a very acute healthcare dilemma. Sorry. Oh, I'm having trouble. Sorry about that. And the people who get liver cancer are in their middle ages. So you have a tremendous loss in quality of life years and productivity secondary to liver cancer. Now the disparities, there are a lot of moving parts to this, and this has been that way with the liver all the way back to the Greeks, who had the myth of Prometheus. It wasn't recently we figured out how to make watches that we understood that the liver is a very interesting organ with a tremendous metabolic capacity and responsible for a lot of our physiology. So when you talk about liver cancer, there's really what I like to think of as intuitive disparities and counterintuitive disparities. And we'll go through them and see how each of them is a little bit different. Intuitively, the disparities originate from the biology of liver cancer and the etiologies of that biology, and they, in effect, generate the prognosis. The counterintuitive disparities are actually that group that we have the most leverage over and can impact people's lives the most with. And they, in my impression, are more important to actually optimizing outcomes and delivering the care than these intuitive disparities that we have. And that can be physician-physician dynamics, physician-family dynamics, and even patient-family dynamics. And we'll spend a lot of time in this because it's something that people don't really think about unless you've been dealing with patients with liver cancer for a long time. And finally, I'll try to convince you that the only way to actually make a dent in disparities in liver cancer on a local level is to actually develop some kind of comprehensive end organ failure structure, not even talking about transplant, but just end organ failure where you address the 5 R's, right? You're offering services to repair the patient who's jaundiced, to replace or transplant the liver. Bulk of your action is rehabilitative, restoring health, and last but not least, performing end organ directed research, be that translational with machine preservation or basic scientific. Now, when you look at the intuitive disparities and we go back to the etiology, it really comes down to what is the itis, osis, oma paradigm, right? Where we start with a normal liver that develops some kind of insult generating hepatitis, and then chronic itis gives you osis, right, cirrhosis, a cirrhotic liver, and then chronic cirrhosis predisposes to the development of hepatocellular carcinoma. It's true that some agents, like hepatitis B here, can hijack this process and through insertional mutagenesis just go straight to cancer, but in these patients, they have essentially a normal liver with a hepatocellular carcinoma like a fibrolamellar, but this group has a much better prognosis and is a very small minority of the total population who is affected by liver cancer. So when you look at the itis, osis, oma paradigm and you think about how do you get into that, it's really through viral infection, alcohol, or non-alcoholic steatohepatitis. These are the 4 most common indications for liver disease in the United States. And this pie graph basically shows you the contribution of both hepatitis B, C, alcohol, and NASH. And it's overwhelmingly the alcohol right now and hepatitis C that are contributing to end-stage liver disease in the United States. When you look at heat maps on the global prevalence of those 4 indications, and you start with hepatitis B, we all learned that Asia and Africa have the densest concentration of chronic hepatitis B. And those countries don't really have uniform healthcare delivery. It's very stratified. So it's no surprise then that a lot of people who come from those areas carry hepatitis B ultimately into the United States, and it's either poorly or not treated at all. Same thing with hepatitis C. Hepatitis C distribution is pretty much through northwestern Africa, Egypt, to Central Asia. And again, due to stratified healthcare, they don't really have a lot of treatment. So when you look at the overall population in the United States of those patients who have hepatitis B and C, it's concentrated within those subgroups. Alcohol, we all know, and there's tons of literature, have demonstrated that there's a tremendous disparity related to socioeconomics and race. So it's not surprising then that patients who develop liver disease carry this disparity. And then also with NASH, non-alcoholic steatohepatitis, that of course is not uniformly distributed through the United States, but actually regionally distributed. So when you look at the actual disparities with respect to the incidence of hepatocellular carcinoma, you find predictably that there's a difference both with ethnicity and that there's a male predominance over a female predominance. However, when you look at mortality, the ethnicity component is retained, but the male to female ratio is dramatically reduced, suggesting, and that's carried through stage for stage. So although males acquire liver cancer much more frequently than females do, their actual survival is much closer to that of females, suggesting that their overall outcomes may be better. And there are reasons for that, primarily associated with access to care, but also some of these soft issues, which I will get to, that are so essential to actually get patients with liver disease successfully treated. The last is the idea of prognosis, right? We don't need to know a lot about liver disease to know that if you have liver disease, it's usually a bad thing, right? And, you know, Hollywood and fiction have always kind of intuitively presented this, right? Be they a zombie or Dracula or some other ghoul, right? They're jaundiced, they're protuberant, they're kind of brain dead, which could be interpreted as encephalopathy. So, you know, the media has picked up that this prognosis is awful, and that alone extends into the medical community when you look at various primary care deliverers who will affiliate any kind of liver disease with a moribund prognosis. So this is an impediment that further accentuates disparities within the community. This shows 5-year survival over a 20-year period, and that basically sums up in kind of a scientific way what we just saw, right? And that is that percent survival at 5 years remains well below 20%. But there is a little bit of hope here, because if you look at this, it looks like the curve begins to change right around the turn of the century, albeit the overall survival number is low. But when you think about patients with liver disease and those who actually get an opportunity to have their disease treated, like liver cancer, it's a very small minority. So if a very small minority enjoys a big benefit in survival, that will translate into a small change in the overall population. So the good news is that actually survival is dramatically increasing in liver cancer. The bad news is most people don't have the opportunity to enjoy that, and hence the overall number stays low and the relative change in the survival curve is attenuated. So as I said, you know, the really exciting news in the last decade is that there are now effective therapies that exist, and all these therapies have type 1 data available to justify their use and have been approved by the FDA. Furthermore, they extend over a very broad spectrum of medical practitioners. So the interventional radiologists have chemoembolization and radioembolization, both of which have been demonstrated in prospective randomized trials to extend the length of a person with liver cancer. The surgeons have ultrasound-guided ablation, which is far superior to radiation, the radiologic ablation or percutaneous ablation when that's indicated. And the radiation oncologists even have stereotactic body radiation therapy, or SBRT, now, which has been demonstrated to be very effective for certain liver cancers and cholangiocarcinoma. And even the medical oncologists in the last 10 years have kind of enjoyed a renaissance in their interest in liver cancer. You know, at first it was the tyrosine kinase inhibitor and sorafenib, and the trial only showed a very small change, and it was very expensive, and the oncologists really weren't that interested in getting involved. So the hepatologists kind of took over, but now with the newer checkpoint inhibitors, they're actually showing some very, very nice data in patients who failed sorafenib therapy. And there's a current trial going on that directly compares checkpoint inhibitors to tyrosine kinase inhibitors as first-line therapy. So, you know, there's widespread good news in that the overall survival is increasing, and it's involving a lot of people in the team. The bad news is that no matter which ticket you check, it's an expensive one. And each modality involves multiple medical visits. There's just no way around it. And a lot of the therapies are combinational. So in order to effectively treat liver cancer, like all other cancers, it's very multimodality through a tumor board. But it's not uncommon for a patient to be passed between radiology, surgery, medical oncology, as they transition from point A to B in their care. There's a lot of physicians involved, and there's a lot of visits involved, and there's a lot of procedures involved. And unfortunately, there's a distinct learning curve with each one of those components of the puzzle. So your radiologists need enough caseload so that your abdominal imaging people can be good at depicting cancers. Your interventionalists need a certain number to keep their skills sharp. Same with the surgeons. And this creates another barrier and a barrier to the patient to actually get through the system, and then that promotes further disparity. And we'll begin to show it to you. You know, when you look at addressing disparity, kind of the easy target are what I call the hard assets. So you'll say to yourself, you know, Brooklyn's underserved. We don't have a liver center in Brooklyn, so boom, we'll just go get all the pieces of the puzzle. But that's actually the easy part. It's relatively easy to assemble physician-level people who know how to deal with these patients. But what's much harder is actually to get these soft areas engaged, because the soft areas are going to be the areas that actually achieve throughput, that allow the patients access into the system, but be able to maintain their continuity with the system and not get lost, diverted, or demoralized along the way. And that's what I mean by these soft areas. And it's more than what the physicians can do. The soft areas can involve physician-physician dynamics, and what I mean by that is that you have to have a high level of engagement with the community physicians to have them overcome kind of the long-standing bias with respect to prognosis. You have to reinforce that with some of your soft team who can ensure them the throughput is good. And you can't really be a one-trick pony. You know, if you're a surgeon and you're a very, very good surgeon, but that's kind of your shtick, you actually become a turntable, right, where the primary care and referrals realize that if most of their serious patients are going to Mount Sinai, they're just ultimately going to bypass you and send them to Mount Sinai instead. And they're going to find out, because somewhere along the line, they're going to get feedback as to exactly where that patient wound up. So as you're trying to decrease the disparities and increase access and throughput, you have to avoid this one-trick pony trap. And you have to emphasize end organ failure, not transplant. And the reason is whenever you talk about transplant, all the baggage that comes with transplant, whether you love transplant or hate it, come to mind: cost and visits and doctors and stuff. And that's an impediment that accentuates disparity at a level that we don't even appreciate because we never even get to see the patient. So you have to emphasize, you know, if a jaundiced patient, they go here. You know, I have a patient with an orthopedic problem, whether it's their head or their toe, they go there. And by doing that, you can actually start to break down the disparity. For example, acute alcoholic hepatitis. How many people know, you know, we probably know that, but how many people who don't really work in an academic center know that we're actively transplanted for acute alcoholic hepatitis now? And the answer is probably a minority, even though it was a New England Journal of Medicine paper. So without knowing that at the provider level, outside the U, these patients won't even be offered an opportunity because they're thinking that they need to be sent to the transplant center rather than to the end organ failure. This person has end organ failure just like anyone else, so send them to the place that takes care of end organ failure. Excuse me. And these soft areas can affect physician-family dynamics, especially at the level of consent, right? So remembering that kind of the hepatitis and alcohol have a big chunk of the causation of end-stage liver disease, and the fact that these patients need a lot of different procedures and everyone needs a consent, you can see that there becomes bias within the family with respect to physician-family dynamics. And you can wear the family out just by the length of the marathon that they have to run. And this is kind of an example. You know, this came up in the chart all the time till about 3 or 4 years ago. The patient has end-stage liver disease from alcoholic liver disease complicated by Hep C. Now, we didn't really know at the time that any alcohol use with Hep C can give you that diagnosis, but already we're kind of tipping our hand that the patient has alcoholic liver disease when in fact they probably never had alcoholic liver disease. And family members who may have drank way more than they did are fine, yet they aren't. That becomes an issue in the family dynamics as the patient starts to chug through the process of seeing all these different providers and getting consent to have their liver cancer treated. And lastly, and most importantly actually, is patient-family dynamics and how that begins to fall apart, especially with patients with liver disease, as you realize that a lot of times the patients will be kind of sentenced by the family for what they had because of the etiology of their disease, be that justified or not. So it becomes a tremendous burden upon the family to kind of get them through the process. And then in the background, there's always this idea of what they actually did to get them jaundiced, even though it may have been totally benign, but that's not the way a lot of families think. And that accelerates or promotes this idea of disparity and unequal access for the patient. So the question is, how do you break that down? And the answer is, it's all these soft assets that make the entire difference between success and failure. It's social work, physician extenders, pharmacy, nutrition, psychiatry, discharge planning, and nursing. In order to really recruit these patients and to lower the disparity, you have to have this team, and this team has to be incredibly strong. Unfortunately, it's almost impossible to assemble this team without the construct of a transplant center. And the reason being is because if you're a one-trick pony, you really don't have the financial and intellectual interest to maintain this team. You know, our payment system doesn't recognize the incredible value these people provide outside of a transplant center. The government was smart enough to realize that this is essential for transplant, so they fund that in transplant. But they're not as smart as to realize that a lot of what liver cancer surgeons do is every bit as complicated as what the transplant surgeons do, but because it's not recognized by the government as being that, we have difficulty retaining these employees, either paying them enough or just having enough clinical material to keep them professionally interested. So you need the transplant center, as much as I hate to say a transplant center, but you need the end organ failure center to actually be able to augment these providers' salaries and fortify your ability to deliver care. So in summary, you know, liver cancer is a challenging topic with respect to disparity. It's not going to go away because of the biologic basis of disease. That biologic basis is integrated into socioeconomics and behavior, and there are going to be obstacles in letting families and primary care physicians kind of get these patients through what they could actually achieve with their disease. The prognostic origins are historical, and only with the bulk of kind of an end organ failure can you actually begin to have sustained community outreach programs that change the overall thinking of providers with respect to prognosis for patients with liver cancer. And only when their outlook and their prognosis and their biases towards prognosis are changed will the actual pipeline of patients begin to change. And all that affects access, whether it be a medical or social impedance. And then by lowering that, the barriers to successful therapy will fall, be they medical systems, patient throughput, even a consent that's multilinguistic at any point in the process, and familial obligations, as the family have people other than the physicians who they can develop a relationship with and learn to kind of relax some of their potential biases as to why they're actually bringing their family member to so many appointments for what they presumably think they may have done. And as I tried to emphasize over and over, you really need the structure of a transplant center to do that, because only then do you have the amount of material coming in that keeps the physician sharp, but you also have the financial and intellectual resources to keep these soft elements, which are so critical to your success at your center. So with that, I'd like to thank you very much, and I'll be happy to take any questions you may have.
So that was a long day with a lot of information, but specifically the residents, you got the opportunity to ask Drs. Ren, Schwartzman, Abulafia about some of the trends in solid organ cancers. And as I said at the very beginning, unfortunately, the results clearly have been trailing the much better results that we have seen for hematological diseases. Let me maybe start with one question. The role of adjuvant or neoadjuvant therapy. Obviously, in liver cancer, we always can go to transplantation under certain circumstances. But let's say, a patient who does not fulfill the Milan criteria, John, where do you really see adjuvant, neoadjuvant therapy?
Right, so there's a lot of wonderful data on neoadjuvant therapy.
There should be a microphone on the podium.
While he is getting the microphone, can you do me a favor? There is a file there called Closing. If you bring that up, that would be great. But go ahead, John.
So there's a lot of good data on neoadjuvant therapy as a bridge to transplant. The problem you have with neoadjuvant chemotherapy is that a lot of the drugs have interactions with the liver, and even the checkpoint inhibitors are marginally indicated in a child's B cirrhotics. But all the patients who have liver cancer, be they a transplant candidate or not, are benefiting by neoadjuvant therapy. Even surgical patients in downstaging with TARE, transarterial radioembolization, you can get a kind of a functional lobectomy on a patient and then take him to surgery and not have to worry as much about minimal hepatic mass. So that is a real therapy. That is a real.
Dr. Abulafia, it does play a big role, I think, in GYN malignancies, but ovarian cancer really has not improved that much. Is that fair to say?
Well, as I showed, we are now at about 40-something% survival. That's been, for us, a significant increase in survival. So we are making very, very small steps, but it's far better than it used to be. I'm sure we would like to see 80-90% survival. The problem with ovarian cancer is that we do not have a screening test, and the complaints are very vague, such as early satiety, some kind of vague pelvic pain, and by the time a patient is diagnosed, it's already stage 3. So for stage 1 disease, survival can be up to 90% or so. But for stage 3 and 4, a significant reduction, and we do not have a screening test that is as successful as cervical cancer. Also because the cervix is an external organ. That is, if you use the speculum, you can see the cervix and collect many, many cells and analyze them under the microscope. And the natural course of disease, that is many years in stage of dysplasia, and later on, if undiagnosed, if untreated, then invasive cervical cancer. So we have made significant progress with this cancer. With ovarian cancer, there is no such thing as a screening test, and by the time the patient is diagnosed, it's already advanced stage. So we have made significant progress in this disease, but most of them present, 75% actually, present at stage 3 and above. So that is the main issue that we're trying to address, and we have markers that are being tested now in order to diagnose it earlier and some formulas. But we're not there for mass screening. But that also has to do with the prevalence of the disease. And so these are the challenges that we face in our field. But cervical cancer is certainly a unique disease, and the cause of HPV and now vaccination, that's really a very, very good model for really addressing cancer care and being very successful, but the frustration is that still we have socioeconomic status that influence the survival, and even we may not be able to share this knowledge in vaccination, everything else with third world countries. And what we talked about 500,000 being diagnosed with cervical cancer every year, and 300,000 women will die. That is really unacceptable. But that's the way it is, so.
Yeah. Dr. Dressner, is there a role for adjuvant, neoadjuvant therapy for triple negative breast cancer stage 3 and 4?
So there's a role for neoadjuvant therapy in all except, there's a role for neoadjuvant therapy in almost anybody. So you can use neoadjuvant therapy for breast cancer in patients who would get chemotherapy otherwise. If you want to do breast conservation with a large mass. If someone has stage 3 disease, neoadjuvant therapy is recommended. It downsizes the disease. There are studies ongoing to see if looking at in patients who have residual disease after neoadjuvant chemotherapy, if those patients are randomized to other treatments, other chemotherapy treatments, so that we can sort of use the patient as their own biological marker of effectiveness of chemotherapy. For example, in some patients, you have a complete loss, all the cancer is gone, you have a complete pathologic response. Those patients are thought to have good outcomes. In patients who have some residual disease, there are studies ongoing to randomize them to other chemotherapy agents or other treatments to see if that, that's after excision. And then you know whether those patients are likely to have a recurrence, et cetera, et cetera. So that's like a high-risk recurrence group. Remember, in a stage 2 breast cancer, at most a third are going to recur. So that's a fairly low risk to randomize. If you can identify the ones who are more likely to recur, then you can do quicker, better studies to show efficacy of therapy. So one of the advantages of neoadjuvant chemotherapy is that you can do more with the information. We know that neoadjuvant therapy doesn't change the outcome on an individual patient, but whether you can identify who can be treated next, yes.
Dr. Schwartzman for pancreatic cancer.
So, in terms of pancreatic cancer, I can't claim even the smallest progress in the past decade. If anything, the incidence is increasing, as is the death rate. And the scary thing is that it's number 2 cause of cancer-related deaths. 2, 3, 4, decide which one you believe the numbers, but it is very high. One of the reasons comes on the molecular level, where actually you have tumor. There are studies demonstrating tumor cells in the bloodstream in patients with T1 lesions. So one of the reasons that we believe that we're not getting good results, even in those patients who are resectable, who may even have N0 disease, is the fact that they already have tumor cells circulating through the bloodstream or tumor cells found in the bone marrow biopsies. So I think the issue of neoadjuvant therapy is becoming more and more important and relevant. Unless we address the systemic issues related to this deadly disease, we are obviously not getting it early enough for us to do anything meaningfully without neoadjuvant. So neoadjuvant, I think, is going to become more and more important in treatment of these patients.
But then getting back to, what this symposium was about, disparity. Your thoughts about how are we going to address disparity issues in the future here at Downstate? How can we improve what we have heard? Because some of the data that were presented with a certain groups of the population clearly disadvantaged in many ways. How can we contribute to some improvement in that regard? And we'll start with Dr. Dressner again, and then walk our way through.
So I think just our being in the community has a big impact on disparities. We pretty much provide standard of care treatment. I would say because of the insurance issues, all of our patients have some Medicaid managed care. There are some insurance-related delays in care, 3 weeks till you get surgery approved, a few weeks to get things approved and get things under control. It is very paperwork intensive and not well reimbursed. So though that is a difficult issue, but we provide standard of care here. I think paying attention to the research, participating in clinical trials, being culturally sensitive, I think is what we can do to improve care.
Dr. Renz?
So I think, the world is becoming more and more transparent, and it's striking just the amount of data that we saw today that's available for comparison. And with that, I think it will be obvious that people really deserve a certain degree of accessibility to care vis-a-vis distance and time. And given that, they will make accommodations based upon perceived quality. So I think that it's very promising because, the more data that comes out, the more, to me, it seems apparent that the people of Brooklyn will benefit by the implementation of certain programs to just give them a relatively level playing field vis-a-vis access alone.
Dr. Abulafia?
I think for cervical cancer, education of adolescents and improvement on vaccination against HPV will make a significant impact. The second thing is educating the community doctors, family practice doctors about symptoms to pay attention when it comes to ovarian cancer, or there's been a lot of attention on pain in ovarian cancer, pelvic pain. This was not something that we really paid attention. So nowadays we pay more attention to pelvic pain and be a little bit more low threshold for ultrasounds, and imaging can also help, and certainly to refer the patient for endometrial biopsy when patient has vaginal bleeding, because that's the most common symptom for uterine cancer.
Thank you. So, again, since I delivered the talk on pancreatic cancer, I'll stick to that. And remember the risk factors that we discussed. It's the obesity, it's the diabetes, it's lack of physical activity. So we can talk about some of the very sophisticated things that can be done in the future, and we can also bemoan the absence of resources and the fact that we don't have the numbers, the granularity. New York is not part of the Sears data. We don't have the ethnic breakdown of the groups that are affected. So that gives us, going back to what Dr. Renz was saying, you need the data, you need transparency. When you don't have that, it's a problem. But what we need to do as physicians, as just people in the community, is encourage healthier living, okay? Look at our cafeteria here. The breakfast special is 3 meats with eggs and hash browns and sauces, and that's... It tastes good. That's the... Okay, we can have that every Monday, for the first Monday of every month. But generally speaking, we as a hospital need to show the way. We need to inspire people to be better, right? So we can't have a 3-meat special for breakfast. We should have 3-fruit breakfast for special. We should encourage our community, our community, meaning us, to exercise more. And if anything, these are the concrete steps that you can take today. I'm not talking about developing new biological markers. I'm talking about making a difference today. That's my pitch.
Dr. Salifu, any final comments, thoughts?
I think I just wanted to thank all the speakers. I think they did a very good job of conveying the message. I like to thank the students for controlling your bladders and getting through this very long day. I'm looking forward to designing a research program with you so that we can move this conversation to a more research-focused way to be able to answer some of the questions that we raised in today's conversations. We want to be the university that provides the answers. So just talking about it is not enough. We want to be the place where you raise the question, then you find the answer. So the NIH has a lot of resources. So I'm looking forward to collaborating with any of these subjects. We have a beautiful health disparity center that we can use to get these grants and then get to the community and answer those questions. Currently, we have an ongoing research program with surgery in colon cancer and pancreatic cancer that is funded. One of the problems was, in order to understand some of these biologic differences, you have to have enough samples. You have to have enough tissue from minority patients that you can study along with other races. If you go to the NIH Gene Bank today, the representation of minority samples is only 4%. So if you were going to do research to find out what are the biologic differences, you would not be able to get the answers. So part of the program we are designing at Downstate is to collect as many samples as possible to create that, to contribute to that NIH Gene Bank, so that when we do big studies, we can extrapolate those results to minority populations. And I'm sure as the surgical program is growing, we would need to do more of those studies. So right now we are in colon and pancreas. Maybe we should be adding liver cancer. We should be adding breast cancer to the biobank. We should be adding cervical and ovarian cancer to the biobank. So there's a lot that we can do as a research environment to be able to answer these questions. So anyway, thank you very much, and I'd like to especially thank you for bringing the whole idea to fruition, and we hope that we'll be able to grow this program next year and beyond. So thank you too.
Thank you. And here it is. I'm getting back to what Dr. Easterling at the beginning said. Exactly in 1 year, October 4th, 2019, we'll have the second symposium on disparities in surgical cancer care. Thanks all for coming. That was a long day. And I know for the residents, I'm sure some of you were arguing about whether or not you could come here, and some of the attendings may have given you a hard time. Whoever gives you a hard time about being here all day long, just send them my way. So you have a good evening, and we'll be back fresh and bright again in the morning. Thank you very much.